Now we come towards multiple myeloma. Regarding the round cell tumors, it's one of the round cell tumors. The round cell tumors, in generally, if you talk about round cell tumors, neuroblastoma and Wilms tumor happen in infants. Eosinophilic granuloma happens in kids. Ewing's happen in young adults, and lymphoma in middle ages groups, while METS and myeloma is in older age group. And infection can happen in any of the age group. These are the round cell lesions. So multiple myeloma is a lesion, round cell lesion in the age group of 50-55. This may affect multiple bones, and if so, it is almost pathognomic of myeloma. Lesions are usually lytic, may be single or numerous. Pain is usually late finding. Tumor may present with pathological fracture. Typically, skeletal survey is appropriate. Bone scan is negative. Other bone scan negative lesions can be lymphoma, eosinophilic granuloma, metastatic renal or thyroid carcinoma, or a very aggressive lesion destroying the bone completely, which can be a cold on bone scan. Labs for multiple myeloma may show hypercalcemia, elevated creatinine. Protein electrophoresis can be done, showing a typical M spike, usually usually IgG or IgA elevated, and is a lab of choice. Important to check the urine for presence of light chain, that is Benz-Jones proteins. This needs marrow aspirate to determine the degree of marrow involvement in plasma cells. Normally is 2 to 3% plasma cells, less than 2 to 3% plasma cells, and more than 10% in minor criteria suggests systemic disease. More than 30% means highly suggestive of multiple myeloma. Treatment is treat with local skeletal support. Our job is to maintain skeletal integrity. Radiotherapy for the lesion, similar to the metastatic disease treatment. These patients mostly always get chemo. Use of bisphosphonate to help control the formation of additional lytic lesions is mandatory. Histology will show a lot of plasma cells and a classic eccentric nucleus and a Hoffa-Clear zone. Prognosis is poor overall, and patients succumb of infection or hypercalcemia. Multiple myeloma is CD38 positive. CD38 positive on staining. Really, a sclerotic lesion variant is seen that may look like METS, and this is usually in somewhat younger males and associated with peripheral neuropathy. This is associated with so-called POEMS lesion, POEMS, polyneuropathy, organomegaly, endocrinopathy, M protein spike, and skin changes, POEMS. Treatment is radiotherapy, but neurological symptoms often remain in this situation. A word for neuroblastoma. This is seen in infants, often present with bone pain or lytic lesion, usually multiple lesions, looks like round cell lesion. Look for the large adrenal mass on CT scan or the bone scan. These lesions often cause periosteal reaction. The histology shows round cells. Look for true rosettae or circular pattern of cells in central neurofibrils. These kids need to care of pediatric hemo-oncologist. Stain is positive for NB84. Now, if you remember, when we start with the Ewing, we said pseudo-rosette formation in histology. And here in neuroblastoma, we are talking about true rosette formation with round cells in neuroblastoma. So this can be an EMQ or MCQ where sometime they will ask that true rosette formation is there. It's a neuroblastoma. Pseudo-rosette formation hint toward with the round cells, hint towards Ewing sarcoma. Chordoma. It's a sarcoma of notochord residual, 85% in the sacrum or the cervical spine, but always at the midline lesion, unless it's a meth. They may be destructive and can be difficult to see on X-ray of the pelvis. Needs to do an MRI. Histology show salivary cell in lobules of blue tumor, which lines up in a row. Remember that the blue ball cells or blue cells on histology are either chordoma or it is a cartilaginous lesion. Treatment is with resection, rarely radiotherapy if margins are compromised. Radiotherapy is indicated for recurrence or unresectable lesions. Prognosis is fair in short term. Long-term survival is 20 to 50%. Local variants are common problems. Must preserve at least unilateral sacral 1, 2, 3 or bilateral S1, S2 roots for any hope of reasonable bowel or bladder function. Most lesions present below the S1 level. They are mostly not good stain on marking, but cells are weakly S100 positive. This is histological difference. Now we talk about benign lesions of the bone. Let's talk about the infection. Infection can happen in usually metaphyseal or epiphyseal region in young adults. It may well be diaphyseal in older adults. X-ray demonstrate multiple lytic lesion in the bone, area in the bone, and coalescence of lytic lesions with sclerosis. Histology show a mixed cell population of small round cells. Pain is typically common feature. Rarely there is soft tissue mass or a tract, but one can see edema and hyperemia on MRI. These are hot-on scans. Looking at a gallium scan, chronic infection or indium scan. Remember that one is looking for the discordant scan versus the bone scan. So the difference between the leucoscan and the indium scan, leucoscan and the technetium scan, the difference can also identify whether it is infection. PET scan is also helpful in looking for difficult infections, particularly around prosthesis. Always consider infection as an option, as it is more prevalent and common in any bone lesion. Infection is the most common epiphyseal lesion. It's not a neoplasm in immature skeleton, but infection. In acute hematogenous infections, Staph aureus is the most common bacteria. Group B streptococcus in newborn. Treatment is with nephthrin oxalin. Beware of fungal infections. Looking for spores in histology. And tuberculous infections such as Langerhans cell, giant cells, rimmed with nuclei and granulomatous appearance in tissue. Pay attention to the histology presented. Remember that in spine, infection typically involves the disc and spread around the vertebral bodies, while TB involves the body and spares the discs. Chronic draining sinus not healing well is one of a risk for squamous cell carcinoma in a chronically inflamed tissue. They can be malignant secondarily. Watch for persistent redness and developing lobular soft tissue lesion in the sinus area. Now we go towards osteochondroma. It's a benign lesion arising from the cortex that may be painful from mechanical irritation. Trauma, fracture, malignant degeneration can happen. Infarct can happen. In the adult, a cartilage gap of less than 1 centimeter is likely benign. More than 2 centimeters suggests a malignant lesion by virtue of lesion growth. Treatment is observation, can be removed if necessary. Get the base and all the cartilage cap, including the perichondrium, usually surreptitiously found from pain with activity in a young person. The lesion should not be growing after the skeletal maturity. If something is growing something is growing in, for example, osteochondroma is growing after skeletal puberty, then you suspect low-grade chondrosarcoma instead of osteochondroma. Some tumor is associated with osteochondroma. Hereditary multiple osteochondral exostosis, MHE. It's autosomal dominant, has multiple lesions. These patients develop skeletal abnormalities. There can be questions regarding, for example, bilateral elbow involvement with reduced range of motion. MHE should be one of the suspicious. So with the multiple lesions, it tethered the radius with bowing and tethering of the fibula at the ankle is common as an exam scenario. MHE, the risk of sarcomas degeneration is considered higher than a simple osteochondroma. It's nearly 10%. The EXT1, EXT2, and EXT3 suppressor gene associated with multiple hereditary exostosis. The gene loss of Indian hedgehog protein regulation may be involved in the disease process as well. We'll talk about the enchondromas. Enchondroma, benign cartilage lesion, most commonly bone tumor in the hand, often seen in proximal humerus and the femur, composed of benign hyaline cartilage, are treated when necessary with curettage and grafting. Radiographically, they generally present a geographic lesion with calcification. The risk of sarcomaceous degeneration is less than 1%. Must consider low-grade chondrosarcoma if the lesion is symptomatic and painful, although some enchondromas may rarely be symptomatic. Beware if the lesion changes and grows over time and develop a lytic focus in a previously calcified center, think of chondrosarcoma, then enchondroma. One important factor is the location of the histology. If a lesion is taken out from the hand and the histological findings are suggestive of enchondroma, similar finding can be prevalent in extremities like femur or the proximal arm. But in that sense, important is to inform the histologist regarding the location from where the biopsy has been taken. So histology can be similar, but due to the suspicion of chondrosarcoma, the treatment may differ. The lesion usually remain warm on bone scan because chondral ossification is a continuous ongoing process. Most lesions can be followed radiographically with periodic examination. Determination of malignant transformation is best made via a combination of patient symptoms and imaging studies, such as progressive enlargement on serial films, lytic changes, advancing industrial scalloping. Now we talk about periosteal chondromas. Almost always they are shown in the proximal humerus. Some reactive bone formation, lesion is painful and typically chondroid appearance on MRI. Multiple lesions like older disease, higher incidence of malignant transformation, probably more than 10%, and bone deformity. Mafesi has soft tissue hemangiomas. Image can be shown of the hand with multiple enchondromas along with changes in calcification in the vascular structure, and it's the highest instance of malignant transformation. These people are guaranteed to have visceral malignancy, and some reaching exceed 50%, and somewhere it's quoted as 100%. So histological risk of malignant degeneration, highest to lowest. Number 1, Maffucci syndrome. 50% risk of malignancy, and somewhere in visceral 100%. 2, Olliers, 10 to 15%. MHE, multiple hereditary exostosis, nearly 10%. Single enchondroma, around 1%. Single osteochondroma, less than 1%. Osteoblastoma, painful lesion, young patient, blastic with a nidus, usually best seen on CT. hot on bone scan. Pain improves with aspirin and NSAIDs. Histology show wound bone with abundant osteoblasts, blood vessel and absence of normal marrow, and surrounding reactive bone. Treatment includes surgical removal of the nidus. If nidus is not removed, it will reoccur. Nursing people with NSAIDs if the patient refuses surgery. But the treatment of choice is one of the best treatment of choice is radio frequency ablation under CT guided. This has 15% failure rate. When in spine, the lesion is usually in the posterior element and may cause painful scoliosis. Otherwise can present in any bone and may be cortical or cancellous in location. When in hand, 15% and usually in the phalanges can mimic inflammatory problems in the digits. Lesion can often be difficult to locate, and CT is the best modality to identify the nidus, not MRI. Lesion around joint or cancellous bone may have a paucity of surrounding sclerotic bone. The pain and inflammatory reaction are felt to be secondary to prostacyclin and prostaglandin produced by the nidus, which is helped by NSAIDs. Classically, the pain is worse with alcohol intake. Osteoblastoma. Histologically, it's similar to osteoid osteoma, but generally greater than 2 cm size. It is mostly common in posterior element of the spine. 50% of the lesions are located in the spine, but can be seen along bones as well. Frequently lytic in the spine and blastic in the extremities, it can be present as either, and usually have a faint sclerotic rim on X-ray and is hot on bone scan. The lesion is painful and lack the peripheral bony reaction of osteoid osteoma. Occasionally, these lesions present as aggressive fashion and may be mistaken for malignancy. Treatment is curettage and bone grafting. Rarely radiotherapy for unresectable or recurrent lesions. The MRI will often show significant surrounding inflammation in soft tissue, which can be confounding, makes one think of more aggressive lesion. Giant cell tumors. Fairly common, lytic, eccentrically located in the metaphysis that may extend into the soft tissue. Most lesions are around the knee, but can be seen in other locations like distal tibia, distal radius, proximal humerus, and are seen at 20 to 40 age group. The lesion can be shown up at sacrum as a mimicker of chordoma. Classically, the lesion extends to the subchondral surface, but in child is seen in metaphyseal side of the physis. Pain is late finding. Lesion can be quite destructive. Remember Campanacci classification. Radiograph, stage 1 in the bone, stage 2 expands the bone with the rim, stage 3 extend into a soft tissue. Local treatment is curettage and adjuvant local treatment with PMMA, phenol, freeze, and or argon beam. So it's extended curettage. Possibly with bone grafting. Subarticular lesion may be treated with some bone grafting next to the cartilage with PMA below for support. Lesion can reoccur and recurrent lesion may require resection. GCT can be hard to treat often when they are in periarticular location. There is a possibility to do radiotherapy in such cases. Medical therapy can be potentially help to augment or replace surgical management in future. Bisphosphonates inhibits the osteoclast and which may decrease the size of the giant cell. Denosumab, monoclonal antibody against rank ligand. This is one of the FDA approved for GCT treatment and can gain a lot of notoriety in the last few years. Regarding giant cell tumor, you have to remember that this is a lesion which can metastasize to the lung. Usually in the exam scenario, it is distal radius lesion which metastasizes to the lung. And this can be benign chondroblastoma, as similar to chondroblastoma, which also metastasizes to the lung. there is no correlation between the apparent histology of GCT and a clinical behavior which can be aggressive. Histology will show multinucleated giant cells with nuclear cells similar to appearance with a background of histiocytes. The histology is classically very similar to hyperparathyroidism. And in multifocal lesions, one must rule out hyperparathyroidism. We talk about aneurysmal bone cyst. Usually in the young children's around or before 20, tibia or the femur may be involved, or proximal humerus. It is a cystic lesion that is expansile and appear multiloculated with a thin rim of bone around the lesion, frequently in the metaphysis. It can occur in almost any location, maybe primary or secondary lesion arising from osteoblastoma or giant cell tumor, or fibrous dysplasias. Lesion can grow very quickly and behave almost similar to malignant fashion. Pain and swelling are common findings. In spine, ABC occur in posterior element. Treatment is curettage and grafting, typically in a state with phenol, cryotherapy, argon beam, or adjuvants. Radiotherapy has a place in recurrence on unresectable lesions, but there is a high potential of malignant transformation. Expandable bones may be excised. Look for multilocated fluid films on MRI. You have to remember that chondroblastoma, giant cell tumor, simple cyst with bleed, or osteoblastoma may have such fluid film levels. Whenever considering ABC in the different diagnoses, don't forget to think about telangiectatic osteosarcoma. So if you have an X-ray shown which shows fluid films and large lytic lesion in an age of 60, you have to consider osteosarcoma. Now we go towards chondroblastoma. I remember it as a younger brother of giant cell tumor. So it's a lytic lesion almost always in the epiphyseal or epiphyseal region in the early teenager, or around the acetabulum, or in the hind foot in adults. May have fleck of calcification seen on X-rays, and this is usually eccentric and abuts the articular surface. Histology show chondroblast with a chicken wire calcification. This is commonly tested, chicken wire calcification for chondroblastoma, and a cobblestone appearance of the cells. Cells stain positive for S100. Usually painful, are seen in 10 to 14 age group when epiphyseal. In chondroblastoma situation, must distinguish from infection in kids and from clear cell chondrosarcoma, which is rare in adult. Remember that clear cell chondrosarcoma is usually in the proximal femur or humerus and should be treated like any chondrosarcoma. Treatment of chondroblastoma itself is curettage and bone grafting. Extending interlesion curettage just as any aggressive bone lesion, but this lesion can also reoccur. This can also metastasize to the lung like GCT, and lesion may present with area of secondary aneurysmal bone cyst. Then we talk about simple bone cyst. So it's a benign lesion, 90% in the proximal femur and proximal humerus below the physis, may even cross physis and epiphysis. Most are asymptomatic and often present as a pathological fracture. Fallen fragment sign is a classic appearance of piece of cortex broken off and fallen into the cyst. It's somewhere written as fallen leaf sign as well. Active lesions abutting the physis are like to reoccur and persist, but lesion away from the physis can be treated if necessary and generally do not reoccur. Treatment is generally observation, but it needs to inject steroids and often require 3 injections or synthetic bone substitutes, or in cases it can be curettage and bone grafted. if there is a high risk of fracture. Lesions that present with a fracture are generally treated conservatively until the bone heals. Then one can deal with the cyst as necessary. Lesion may expand the bone to approximately the width of the physis, and the cortex may even be thin, but never will be true endothelial erosion or a soft tissue component in these lesions. Eosinophilic granuloma. Both solitary and multiple forms exist, are felt to be reactive and not truly a neoplasm, mostly seen in the first and second decade. Lesions are lytic and may have reactive periosteal changes. Looks like a round cell lesion on X-ray. Pain is very common and swelling is not uncommon. Lesions are most common in skull, ribs, and long bones. Remember, vertebral plana in the spine is one of the differential is eosinophilic granuloma. The collapsed vertebral lesions are usually healed but never regain their full height. These patients should be braced. Lesion may resolve spontaneously but frequently are biopsied for diagnosis. May require curettage and grafting. Occasionally low-dose radiation for lesions that have significant symptoms. If systemic disease, this may require radiotherapy. This may require chemotherapy. Remember hand-shoulder Christian disease, a more diffuse form, and letter-sweeve disease, a more severe disease, which is fatal in infancy. Histology show Langerhans histiocysts with the nuclear cleft, kidney bean shaped, and may have eosinophils as well. This is very commonly tested. Electron microscopy show characteristic Bayer-Beek bodies, which is racket-shaped organs in the cytoplasm. Lesion usually stains positive for CD1A. Langerhans cell histiocytes, kidney bean-shaped nuclear clefts, and Bayer-Beek bodies. This is very commonly tested in exam. Page disease. A problem with bone remodeling. This is essentially excessive resorption and formation. The coupling mechanism of bone resorption and formation is lost. Pain frequently associated in the lesion around the knee and the hip. X-ray show classic changes. The X-ray will show number 1, coarse purposeful trabeculae. Number 2, lytic blastic lesions. Number 3, enlarged bone. Number 4, thickened cortex. Not all of these may be apparent with every case on X-ray. Stages can be lytic and blastic, and burned out, and usually progress in that order. So lytic and blastic, and burned out. Exam can show skull radiograph, which early on shows the large progressive lytic area called osteoporosis circumscripta, or late mixed changes like cotton wool exudates. Bone scan will be hot and will essentially light up the entire area. Histology show mosaic pattern to the bone and fibrous changes to the marrow. Many total joint cemented for relief of the pain. In the adult pathology, the question can be regarding how to prepare for total hip replacement, and important is to have the patients on bisphosphonates for a while, and backside bleeding is an issue while cementing. The disease is not now felt to be autosomal dominant, and there is some interest in the gene involvement as a 5q35 QTR gene. Treatment is with bisphosphonate the effect includes inhibition of osteoclast, and thus it helps with the bone pain and the resorptive changes. Remember that these people have fractures that heal more slowly than normal, but generally do heal, and the bone strength will be never back to normal. Lab findings will include elevated alkaline phosphatase, elevated hydroxyproline, which is collagen breakdown marker, and increased urinary N-telopeptide and alpha-C-telopeptide. This is also commonly tested collagen breakdown marker, elevated hydroxyproline. We talk about some words about Paget sarcoma. It's a horrible problem in long-standing Paget disease patients. Develop pain in not responsive to previous treatment and eventually a big mass with destruction of bone in a Pagetic site. Remember to look for underlying Pagetic appearances with superimposed destructive area and the typical soft tissue mass. Pathology show high-grade sarcoma, often osteosarcoma. Prognosis is uniformly fatal. Lesion is treated like osteosarcoma, but often the patient are too old to get chemotherapy. Some words about fibrous dysplasia. It's a benign condition, monostatic or polyostatic, usually found in serendipitously, but can be symptomatic. Lesion can be cystic in appearance, especially in proximal femur, and may be expansile. This lesion is commonly discovered around the hip and can occur anywhere. Ground glass appearance on X-ray is one buzzword for fibrous dysplasia. But fibrous dysplasia can occur like anything like infection, Mets, cartilage lesion, or eosinophilic granuloma. They are typically, histology will show Chinese letter C's and O's. They are surrounded by spindle cell fibrous tissue. These are typically no rimming osteoblast on the trabeculae. This is also commonly tested. No rimming osteoblast in the trabeculae and Chinese letter that are surrounded by spindle cell fibrous tissue. Treatment is observation and need curettage and cortical bone graft with internal fixation. Remember, use cortical graft. Cancellous will resorb and reform into similar fibrous tissue. Fibrous dysplasia heals with the fibrous dysplasia. Lesion has high expression of FGF33, fibrous growth factor 23. The active mutation is GS alpha protein on chromosome 20, Q13, which affect the cyclic AMP signaling pathway. There is a general consensus that they do help by bisphosphonates. Remember, polyostatic lesions like cafe olate spot, coast of Maine, or ragged as opposed to coast of California seen in neurofibromatosis. So the cafe olate spot here are coast of Maine, while in neurofibromatosis they are mostly in coast of California. We are talking about the McCune-Albright syndrome, which is associated with fibrous dysplasia endocrinopathy, and in that the cafe olate spots are ragged and irregular shaped cafe olate spot, not like neurofibromatosis where they are plain and smooth edges. Other problem which can happen with the Paget is diabetes, thyroid and parathyroid problem, and Cushing disease. Some words about the osteofibrous dysplasia. It's an uncommon lesion that is confused with the fibrous dysplasia or adamantinoma. Some have suggested the osteofibrous dysplasia is a potential precursor of adamantinoma. Anyhow, osteofibrous dysplasia is benign, locally aggressive, and occur almost exclusively in the anterior cortex of tibia. They are typically more in the younger patient than older. Angular anterior bowing deformity of the tibia is common. Histology show benign woven bone with rimming osteoblast and fibrous tissue. Treatment is controversial. Usually observation in the young child. They may be removed if symptomatic and enlarging in adult. A differential diagnosis will be adamantinoma, which is more aggressive, more destructive, and has a nest of epithelioid cells on histology. There's a malignant representation and also has similar involvement of the tibia. Treatment of adamantinoma is wide intercalary resection. Some words about non-ossifying fibroma. It's a benign eccentric lesion seen in metaphysis of the long bone, usually well marginated. This lesion is seen in some 30% of skeletally immature individuals, frequently discovered after a minor trauma. They usually spontaneously regress with time and leave a moderately dense area in the bone. Occasionally may leave a giant bone island after healing. Histology show swirling fibrous tissue with giant cells, some histiocytes. Treatment is generally observation, but may include curettage and bone packing if symptomatic. May be multiple and usually large and associated with Jaffe-Campanaki syndrome, which includes visual problems, mental retardation, and cafe-au-lait spots. This ends the bone part of the oncology. In the next section, we will start off with the soft tissue lesions.